Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to Health Matters, a comprehensive chat. Another Tuesday night slot, your regular medical slot from the Islamic Medical Association. Health professionals attempting to empower you through this educational forum. Tonight we're discussing gastroesophageal disease with specific emphasis on acid, reflux and peptic ulcer disease, and we are honored to have Dr. Nazir Chopdat, a prominent gastroenterologist in Lenmed Clinic in private practice. Welcome to the show, Dr. Nazir Chopdat.
Assalamu alaikum, Yakub. Jazakallah for the invitation again.
Alhamdulillah, alhamdulillah Rabbil Alameen, wal aqibatu lil muttaqeen, was salatu was salam ala ashrafil mursaleen, Sayyidina Muhammadu wa alihi wa ashabihi ajma'een. We have a well-known hadith that the Nabi sallallahu alayhi wasallam mentioned, wherein he said that the son of Adam can strengthen his back with a morsel of food, and if that is not sufficient for him, then he can have a third of solids, a third of liquids drink, and leave a third empty, where he mentioned a third with breath. And that is such a very old quoted hadith, and so commonly, but how often do we comply to that? Because that is directly related again to our discussion today, where we will be discussing lifestyle modification, how important it is for us to control the way we eat. And we've been doing that throughout the months when we've been discussing various chronic diseases like cardiac disease, hypertension, diabetes. And again, we have to reflect on this hadith, a very basic teaching from the Nabi Sallallahu Alaihi Wasallam, the master of creation, where he gave us a comprehensive lifestyle and told us what to do and how to behave in terms of various modalities of behavior, especially our eating and our health. And of course, our bodies are an amanat that we have to look after. And again, this will come through in today's discussions when we're discussing acid and reflux disease as well as peptic ulcer disease, where we'll see the importance of eating correctly, and not only in quantity but also in quality. So Nazir, I'm sure you agree with that.
Absolutely, Yakub.
I mean, who's going to disagree with the hadith? But I mean, perhaps you maybe want to add something to that before we start talking about the medical aspects.
Absolutely. I mean, as you've said, Nabi Karim Sallallahu Alaihi Wasallam has said that food is nutrition, is substance for us to have to survive, but everything in moderation as well. If we eat too much, it's a problem. If we eat too little, it's a problem as well. And if you see particularly acid-related disease, mostly it's related when one eats too much or one eats the incorrect foods. So inshallah we'll discuss that as we go along.
All right. So I've tried to break up today's discussion into two parts. I think first we can concentrate on reflux and acid-related disease with reflux. And then later on we can go on to peptic ulcer disease. But the lines will also be open, and we're hoping that the viewers will call in, inshallah.
Inshallah.
All right. So we'll start with slide 1, which is relating to gastroesophageal disease and reflux disease. And maybe you can just perhaps tell us what is that? What is it in terms of definition? What is actually acid reflux disease?
So everybody usually asks, what is reflux disease? Firstly, reflux is a normal physiological mechanism. We all have reflux. You eat something, you go out to a wedding, and you'll find that some food would come or something would come up from your tummy into your food pipe. And that is simply reflux disease. And when we talk about the definition of reflux disease, we are saying it is the movement of certain components, which can either be food, it can be fluid, and sometimes can also be air that moves from your stomach into your food pipe. But this movement begins to cause troublesome symptoms in the patient. And that's a key note, troublesome symptoms in the patient.
Slide 2 will probably highlight some of the things you just mentioned now. So the troublesome symptoms that you're talking about, where there's a movement, so this is a mechanical thing?
This is purely a mechanical thing.
Right.
However, there's few other conditions that can predispose to causing reflux as well. But we'll discuss that as we go along. If we look at the classification of reflux disease, which is on slide 3, it should come up now. This is very important. It may be a bit too technical for most people to understand, so I will go through it in a little bit of detail. Whenever we think about reflux, most people think it's food or acid that's going up into the food pipe. However, this acid can cause both damage to both the food pipe as well as to other organs related to the food pipe. Amongst them particularly, we know of reflux itself, or typically what we would call heartburn is what it is. but it can also be a cause of severe cough, laryngitis, dental erosions, asthma, chronic lung disease, etc. So those are the other symptoms that patients with reflux disease can present with.
Maybe let me just interrupt you. Can you perhaps tell us, because in our practices, when we're referring patients to the specialists, there's always a little bit of confusion. The patient is coughing and they think they got asthma, meanwhile it's related to reflux.
Absolutely.
And then sometimes it can be the other way around, where your symptoms get confused. You're not sure whether you're dealing with reflux or spasm, bronchospasm from asthma. You just want to highlight some of the symptoms. Is there any symptom that can highlight one, or perhaps it's too difficult to know the difference just based on the patient's history?
No, obviously on the patient's history, if a patient comes into to the practice or to the doctor complaining particularly of heartburn, that's the first sign. And heartburn is a common symptom. So what happens? Doctor, I feel a burning sensation behind my breastbone. That's the most common symptom that will elude one to say that the patient has probably got reflux disease. However, this heartburn is often ignored, or sometimes it's kind of worrying because one thinks that they may be having a cardiac problem as well. But we'll talk about that a little later. So they have reflux disease, they have this heartburn, but it goes on, and eventually they have this history of persistent coughing that doesn't go away. And what often happens is that they see the doctor, they get antibiotics after antibiotic after antibiotic, and obviously nothing's really happening, but the cough seems to persist. So that's one of the classical signs. The other one that we see also is patients that complain of recurrent ear infections or otitis media, which can also be a symptom of reflux disease as well.
The otitis media, is it in a particular age group? Is it more in the younger group?
Yes, more in children
rather
than adults.
Rather than adults. All right, so that's the definition, the causes, mechanical pathogenesis and a cause, right? Anything else on that slide perhaps you want to highlight to bring up?
One of the most common manifestations also of reflux disease that patients present with is chest pain. And that can be a very scary sign.
Of course,
because,
definitely.
if you, well, I suppose any particular age group and you present with persistent chest pain, the first thing one thinks about is cardiac, and obviously are they having a heart attack or not.
Right.
But reflux disease can also present with persistent amount of chest pain as well. Then the problem with reflux disease is that it's not a simple disease. If reflux is not addressed urgently, or if reflux is just taken for granted, it has various complications, which I'll show you a few pictures a bit later as well. What are the complications of reflux?
Okay, so in terms of signs, symptoms, patients will present with a discomfort, with heartburn, with chest pain, and then obviously we'll try and go through the different causes of those symptoms. Sure. Would you then start looking at perhaps what would be the most definitive way of finding out whether they have reflux?
Absolutely. So there's various different ways in which you can find out how a patient has got reflux disease. Those tests include imaging, which means certain type of x-rays. One of the x-rays that we talk about is called a barium swallow. It's basically an x-ray whereby you drink a white liquid, and after a few minutes the radiographer or the x-ray department will take a series of pictures, and that would then look and see whether this white liquid comes up into the food pipe. So that would be almost suggestive of gastroesophageal reflux disease. The second test that we do is usually a gastroscope. A gastroscope is a procedure whereby one takes an endoscopy. In simple terms, we call it a camera that goes into the food pipe, down into the tummy and into the small part of the intestine. And it's able to assess everything else that's there. So it looks at peptic ulcers, looks at reflux disease, looks for any other complications of reflux disease as well. The third testing, which is not commonly used but it should be used, is something we call pH testing. Remember, we're not only refluxing acid. We're refluxing acid, we reflux bile, we reflux air, we reflux water, and all those things can cause this particular problem. So by doing a pH testing, one is able then to identify what exactly is being refluxed up into the food pipe and accordingly treat it as well.
Now, in this day of high medical costs, we're finding a number of patients wanting to differentiate what is the best test for them that is most cost effective, because not everyone can afford a scope or a barium swallow or the imaging.
Absolutely.
But they may be able to afford a part of it. That's the one aspect. And the second thing is sometimes even the funder, the medical aid, is going to tell them that, listen, you know what, go for the cheaper test because you've chosen a lower option of something of that nature. So the difference between the barium swallow and the endoscopy, gastroscopy, in terms of your findings, is one superior over the other?
Before we even go to that, there's even a much more simpler and cheaper test. It's called the PPI test. A PPI test, PPI is a term that we use for proton pump inhibitor, which in simple terms is your antacid therapy. That means your omeprazole or lansoprazole or one of those particular medications. And what it simply means is that if a patient comes to you with symptoms that are classical of reflux disease and they do not have any other warning signs, then you could put them onto this therapy for a period of 4 to 8 weeks. If they respond, then automatically that proves that they've the reflux
an element of it.
there is. And then if we look at other modalities, I would rather go with the gastroscopy for two reasons. One, the gastroscopy allows you to actively visualize how much damage has been caused by the reflux, and also allows you to take biopsies to look for any other complications of the reflux disease as well. It's an invasive procedure, but it has more benefits, and it's technically not very difficult, and most patients tolerate it with ease.
So when would you then choose a barium swallow over a gastroscopy?
If the patient has got a specific warning sign of difficulty swallowing, where they say, doctor, I'm eating but the food is not going down, it gets stuck in the middle of my chest, or doctor, I've got severe pain on swallowing. In that case, one may actually have to use both modalities, but I would usually start off with a barium swallow first, because often patients that have got reflux disease for so many years can develop strictures or narrowing of the food pipe. And one wouldn't want to go and do an endoscopy without knowing what the anatomy
It'll
looks
cause
like
problems.
inside.
So those are some of the complications which we'll discuss after the ad break, to which we are going now. And after that, we'll be back, and the lines will also be opened for your calls, and the number will appear at the bottom of your screen when we do get back. Assalamu alaikum. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters, a comprehensive chat by the Islamic Medical Association. Today we have Dr. Nazir Ahmed Chopdat from Landmed Clinic discussing gastric acid disease, reflux disease, and peptic ulcer disease. We've been going through the various imaging and diagnostic modalities to diagnose gastroesophageal reflux disease, and we looked at the different modalities, and we were differentiating. So we'll be waiting for the calls from the viewers on 011 086 7700 or 1 or 2 or 3, and the number appears at the bottom of your screen. The lines are now open. But while we're waiting for your calls, Nazir, what are the real complications? I mean, why go through all this trouble besides the symptoms? So sometimes patients say, you know what, I'll just take a Rennies and I'm happy, or I'm taking my Eno and I'm fine.
Absolutely.
But is he fine or is she fine doing that, especially this being a long-term problem?
Okay, absolutely, Yakub. You know, reflux is a chronic disease. It's something that goes on, and often people take it for granted. So I've got a nice slide number 7, which will show the complications of reflux disease. It should come up now. So if you look at that slide,
good pictures there.
Now, so exactly, this is the question that I get asked often in practice. So, doctor, so you've done my scope, I've got reflux.
Yeah. So what? Yeah.
What's the next step? And I often show them this particular picture. If you look at it, there's 4 pictures at the bottom there. And the first one is what we call non-erosive disease. And I'll just explain a little bit on that.
Please.
So non-erosive disease is where you've got symptoms of reflux, but when we do an endoscopy on you or we do a scope on you, we don't really see anything. So you do a scope, but you don't really see features of severe reflux disease. But the symptoms is very classical. The patients complain about the heartburn, etc. So that's called non-erosive reflux disease. And the second picture, if you could put it back on again, is known as erosive disease. Now, erosive disease, this is where the problem of reflux comes in, where patients have got symptoms of reflux disease, and it's to such an extent that it's causing damage to the esophageal mucosa.
Okay, we've got another caller, and then we'll go through that. Assalamu alaikum.
Wa alaikum salam.
So,
I would like just to say that I've got acid reflux, and I was at the doctor, and he put me on Nexium for 6 weeks, And then when I stop my Nexium, I feel that my chest is burning, and just in between I get like a pain.
Okay. Assalamu alaikum. Brother, exactly that, and that's what we would call the PPI test.
Yeah,
Whereby
that's right.
when you take your Nexium, well, Nexium is what we call a PPI, right? A proton pump inhibitor. So what it does, it suppresses the acid in your tummy. And when you take the Nexium, what you're simply doing is you're suppressing the amount of acid in your stomach, and as a result, there's less acid being refluxed into your food pipe. Now, the ideal duration of therapy for somebody with proven reflux disease should be 4 to 8 weeks of therapy. Anything shorter usually would exacerbate the symptoms. So what would be recommended is you continue your Nexium for a full 8 weeks, and if there's no improvement after that, then we got to do what we call is either double the dose of the Nexium, or change the Nexium to another drug, or use it on demand. That means when you feel the symptoms, then to take it again.
What dose are you taking, brother?
I'm taking 40 milligram, and once every morning before meals.
Excellent. I mean, that's an adequate dose that you're taking, and that's a nice point that he brings up there as well, is taking it before meals. The ideal time to take your Nexium or Omes or Losec, whatever it is half an hour before breakfast, because that gives the patient the best benefit of it. And how old are you, if you may ask?
32 years.
32. So again, very young. You know, we usually see reflux usually from all age groups, but at this particular age of 32, one also gets a bit concerned in terms of the diet, etc., that the patient may be taking as well.
Okay, the doctor also put me on a weight loss. So I've lost 10 kilos. I was 92, now I'm 82.
Alhamdulillah. I think that you've done, in fact, your weight loss and your dieting program is probably more effective than your therapy itself. So that is something that you need to continue all the time.
Any specific foods that causes acid reflux?
There's multiple foods, and remember, acid reflux is a mechanical disease whereby there's, at the lower part of your food pipe, we usually have a little valve, and I call it the one-way valve. It only allows things to go in, things shouldn't be coming back up. And often there's various things that can contribute to it. So what I'm going to do now is I'm just going to switch to a slide that will show what can cause reflux disease as well. And so let's get slide number 5 for us on there. Then you'll be able to see the stuff that can cause reflux disease in terms of food.
While that slide is coming up, Nazir, would you recommend after this Nexium treatment that he goes for a scope or a barium, or should he just continue?
No. If he hasn't had an improvement in his symptoms, then endoscopy is definitely advised in him. Yep.
Did you hear that, brother?
Yeah, I've heard that.
Okay.
So if you look at the screen, there's a significant number of contributing factors. Things that we like: chocolate, coffee, cola, tea. But this is basically foodstuffs that affects the valve mechanism. And this can obviously exacerbate reflux disease. Okay.
So, Jazakallah for your call. We have another caller. Assalamu alaikum. Okay. Assalamu alaikum.
Okay, hello.
Hello. Assalamu alaikum.
Walaikum assalam, doctor.
Ji, how are you?
Fine, doctor.
Alhamdulillah, ji.
Doctor, what I want to find out is, the one question is, when does one go for an endoscopy, and should you do it once in your lifetime?
Okay.
And what are the risk factors?
Absolutely, a very, very important
Very good question, yeah.
Yakub.
Excellent.
And this is classically what patients worry about. You know, whenever you mention you want to do something, first thing that you should ask your doctor is obviously about the side effects, etc. So endoscopy, there's brother, can you hear me?
Can you?
Oh.
Okay, he listen on the studio.
Okay, so there's multiple.
He's listening on the screen.
Yeah, so there's multiple places that you can do endoscopy in. The advice would be to go to a center and to a person that is specialized in doing endoscopy. You get lots of people that do endoscopy, but you need to go to somebody that interprets the endoscopy in the correct setting of the patient. If we're looking at gastroscopy, there's no real particular side effects of it, but there's always a risk of perforation. That means if there's a narrowing in the food pipe and we do the scope, and without knowing that there's a narrowing, you may push the scope a bit too hard, and that may cause a perforation. That's particularly the most important side effect. The other side effect for gastroscopy relates particularly to the anesthesia. Some people do gastroscopy or endoscopy without anesthetics. It can be done. It doesn't have to be done with anesthesia, but usually we do it with a little bit of sedation to keep the patient calm, to keep the patient pain-free, and also so the patient doesn't kind of remember what's transpired during that time. In that way, I find they're a bit more accommodating to have the procedure done.
Okay, and then we'll answer the other question just now, whether he needs to do a repeat endoscopy later. But we have another caller. Assalamu alaikum.
Alaikum salam, Nadira speaking.
Assalamu alaikum, Nadira. Jay.
I haven't got an ulcer, but I've got a hernia. I had scopes already. I'm using Ultrasec twice a day. I need to get the operation, but because of diabetes and high blood, they refuse to do the operation.
Okay.
Anything else that I can use?
Nadira, if I ask you two questions first, how old are you?
I'm 49 years old.
49, okay. And okay, you know, you should never ask a lady her weight
Yeah,
on.
but you need to know this in this case.
So I need to know what is your weight, Nadira?
Oh, I'm a big lady, doctor.
Okay, no problem. That's fair enough for us. So Nadira, Yakub, the operation that Nadira is talking about is something called a Nissen fundoplication. It's a procedure that we usually do where we wrap the distal part of the stomach, or proximal part of the stomach around the food pipe. Now, Nadira, the problem with it is it's not a difficult operation to do. It can be done using a laparoscope, and there's lots of experienced surgeons that are out there. But one has always got to look at the risk and the benefit of doing surgery in a patient. And often diabetes, hypertension, dyslipidemia, very obese patients are at high risk. And you may then have more complications from the surgery rather than from the hiatus hernia itself. So in that case, what do? We have to offer you something. So you're already taking twice a day dose of Ultrasec, and if you're still symptomatic, the most important thing that you can do, Nadira, is try lifestyle modification. That means try to lose as much weight as you possibly can, try to correct your dietary habits as well, increase the amount of exercise that you're doing. And in terms of medication, sometimes if one medication doesn't work like Ultrasec, your doctor may then change you to a different class of medication. Often that often helps in the patient. Yeah.
Okay, shukran, doctor, so much.
Jazakallah, assalamu alaikum.
Some important issues there in Nadira's case. The anti-diabetic medication, any relation between that and the reflux that arises from hiatus hernia?
Absolutely, anti-diabetic medication. In fact, we go to slide number 6 now. We'll be able to show you a few. That's it. These are all drugs that affects the valve mechanism that we spoke about. Yeah. And amongst them, you'll find nitrates, diazepam, antihypertensive medication. All these things affect this mechanism, and that can all contribute to reflux disease as well.
So unfortunately, people like Nadira are in a bit of a catch-22, eh? Well, I mean, they need to control their diabetes and the hypertensive.
Absolutely.
The first line, second line drugs cause a bit of reflux, and now she's got a hiatus, which is a mechanical issue. So she's in a bit of a catch-22 there, so she has to just try and cope best with her lifestyle.
Absolutely.
And then bring control to those diabetes, hypertension as best as possible. But she's not a surgical candidate, right?
Not at this moment and from what she's telling us. Yeah. But again, lifestyle modification will improve her diabetes and improve her hypertension as well.
Yeah. So she can do a lot for herself, but she must try her best, inshallah. Sure. Another caller, assalamu alaikum.
Wa alaikum salam wa rahmatullahi wa barakatuh. Dr. Sahab? I just wanted to find out about, I'm taking a capsule called omeprazole.
Omeprazole.
What I wanted to actually know is, does the omeprazole, has it any side effects later on? I'm 71 years old.
Gee, alhamdulillah, fantastic question.
Alhamdulillah. What dose are you taking? What milligrams, brother?
Milligram. Just quickly give me the...
Is it 20 or 40?
Ask my wife to quickly...
All right, while she's doing that,
I'm taking quite a bit of tablets, Dr. Saab. I'm taking 3 tablets for high blood pressure.
Gee.
I'm taking 1 tablet for prostate.
Okay.
I'm taking 1 capsule at least. I'm taking 1 capsule for this reflux.
Right. Okay.
Okay.
Now they put me on, I couldn't sleep well. I'm taking one tablet for sleeping as well.
Sleeping as well,
right.
alhamdulillah.
Okay, all right.
Tell me, for how long are you taking your omeprazole for?
Omeprazole, quite a while, Dr. Saab.
Quite a while,
taking
yeah?
quite a while now.
Okay.
I'm taking, and I'm feeling very well. I don't feel, I don't feel
Symptoms.
food coming up at all.
Alhamdulillah.
In fact, I feel like eating more even at night. I feel like eating more, and I don't want to quickly get into bed too.
Okay.
I want it to be, be a little bit. It must not. It must settle down. Food.
Ji.
Okay.
Okay. So we're going to go through. We're going to go through a few things.
I bought this tablet in India because the capsules are cheap in India.
No
Okay.
problem.
Okay. We'll answer your question, brother.
It's written here, omeprazole capsules, 20 milligram.
20.
Okay, 20 milligrams.
daily. Yeah.
Okay, so alhamdulillah, our caller brings up a very important point.
Yeah, is a
Remember,
longevity.
every drug that we prescribe as practitioners has got a side effect.
Yeah,
We
absolutely.
cannot get away from the side effects, unfortunately.
Yeah.
So omeprazole, the proton pump inhibitors are one of those medications that do have side effects. And if we go to slide number 21, we'll just briefly show them quickly what some of the side effects are of these medications. So slide number 21, 22, slide number 22 for us, please. Okay, so this may not answer the question directly. However, this is incumbent in to tell patients that if you take your medication for a long period of time, there is some evidence that you can have a problem with Helicobacter pylori, which is a little bug that lives in your tummy. You can have a problem with getting diarrhea, a problem becoming osteoporotic, a problem with other side effects regarding the
little
medication.
bit on the kidney also.
Absolutely.
Yeah.
However, these side effects are very, very rare.
Okay.
And that's the important point that we need to make. So thus far, patients that have taken this, the side effect profile is very rare.
Okay, so there is side effect profile. It's rare, but obviously it does exist. We have another caller. Assalamu alaikum.
Alaikum salam.
Salam.
Doctor,
Ji.
can you hear me?
I can hear you well, Ji.
Yeah. What I want to find out from you is, you see, I've got a good appetite, but I don't put any weight on. I was 64 and I'm at 60. Could there be something wrong with the gut, I was told?
Absolutely.
And how do you have this gut checked?
All right. There's a very important question that the brother puts forward. Weight loss is a very, very important symptom. It's something that we kind of take for granted. However, patients are the ones that usually tell us the best. They tell you a story. I often ask them, when you ask them what is their weight, they say, I'm okay. But when you ask them what is the size of your trouser or your dress, have you gone less? And that's often when you begin to pick it up. Now, what's an important question to ask you is that this weight loss, is it prolonged? Is it over a short period or over a long period? And that's important. If patients have got significant weight loss over a very short period of time, then it needs to be investigated. There's not only gut problems that can cause weight loss, there's other diseases that can cause weight loss as well, other chronic diseases, endocrine diseases like an overactive thyroid as well can cause it. But definitely the GIT is one place that you would look for. How do you look for that? You need a full investigation with a few blood tests, maybe some x-rays, and eventually endoscopy as well to see if there's any other cause of the weight loss there. Okay.
Okay, so the recommendation is basically you must go for further investigations and get this weight issue addressed thoroughly.
Absolutely.
We'll take another ad break, after which the lines remain open. Assalamu alaikum. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to Health Matters, a comprehensive chat. The last segment of tonight's program on acid and reflux disease and peptic ulcer disease. And we will go straight to the caller. Assalamu alaikum. Assalamu alaikum.
Salam.
Go ahead with your caller, brother. Question?
Yeah, my question is I want to speak to the doctor.
Yes,
No
you can
problem.
go ahead.
Assalamu alaikum.
Wa alaikum salam.
I want to know, the lady is 77 years old
Ji.
and she got cancer and she got a very heart weak, right?
Right.
And they can't give her chemo. because of her heart is weak.
Right.
Then what advice the doctor can give me?
What cancer does she have, brother?
I don't know what cancer, but she's in stage 3.
No, but is it stomach cancer?
It may be a stomach cancer.
Okay. Look, there's.
But she got a heart problem and her heart is very weak, but she's 77 years old.
Okay, no problem. We'll try to answer that. There's very limited information, but you know, it's a very difficult one to answer, Yakub.
Yeah.
Because
no, it's not difficult because I'm not a doctor, but I'm an acting doctor.
Okay.
So this patient, I given her something to do which is helping her.
Right.
The first thing I told that whoever is in charge of her, put in asparagus, right?
Right.
Asparagus will cure cancer. And the heart, you know Kulunji stick?
Yeah. Brother, the question is, we're discussing acid and reflux disease today. And
yeah, I even got answer for that too.
Yeah, so can you just perhaps stick to the topic, because we can't have a very wide discussion. We just want to discuss the topic because we've got other callers coming in through.
Peptic ulcer. I see the advert.
Yeah, so maybe you can just mention your comment and then we can move on, brother.
Okay, ma. Peptic ulcer, the best thing for peptic ulcer is, anybody who's got peptic ulcer, when they're going to sleep in the night, is just take a little bit, quarter of a finger of zambat and they must suck it. What it does, it goes and settles on the slow, it'll cure the peptic ulcer. That's why they say that there is 3,000 sickness in this world, and to mankind 1,000 is known. You're right.
Absolutely.
And 2,000 is left in Allah Ta'ala's name, in hand. So doctors can't cure everything. You know?
100%. Brother, I agree with you totally. You know, shifa comes only from Allah subhanahu wa ta'ala.
No.
We are merely but means.
I always pass the message on. Because as I said, I'm not a doctor, I'm an acting doctor, you see. That's why I'm seeing this program. For peptic ulcer, I got the problem, I got the distinct cure for that thing. Even if you got like chest pain, I even got a cure for that too.
Brother, Jazakallah for your comments, and we appreciate it. And of course, all the shifa lies, brother, the shifa lies in Allah's hand. We can't take your number down. It's for the viewers to know. You can leave your number with the studio. We're answering questions from the viewers. And may Allah grant shifa to all your patients too. And ultimately, the cure lies in His hands.
If somebody got a problem, they can always ring me.
Yeah, you can leave your number with the studio, brother. Jazakallah khair for your call. Assalamu alaikum wa rahmatullahi. Okay, that was a caller with alternative therapy, and we've always maintained, and we've had alternative therapies here. And Prophet ﷺ has said that for every disease there's a cure.
Absolutely.
And we should look for the cure, and we don't know where that cure lies. And whoever has the skills and has been granted the skills, may Allah grant healing in his hands, inshallah.
Absolutely, amen.
So we'll go back to one of the questions we had earlier, is the endoscopy. Remember the brother asked, he has one endoscopy, a diagnosis is made, treatment is initiated and instituted and maintained. When does he go for a repeat endoscopy, or should he go for one, or shouldn't he?
You say it depends on the age group of the particular patient. If they're young people and they're responding to the therapy, then there's no need to repeat the endoscopy again. If they are a bit of an older age group and you haven't done an endoscopy in the first place and you've given them treatment, and the symptoms are not improving, then those patients should go for endoscopy. And if the patient has had an endoscopy, then the time for repeat endoscopy, or the guidelines suggest, is only if you have a proven peptic ulcer, not for reflux disease. So if you have a proven peptic ulcer, or you've had a mass, or you've had anything else that they particularly found, then you can consider doing endoscopy to see if it has healed correctly.
Okay, so it very much depends on the initial diagnosis.
Absolutely.
And other symptoms that may or may not occur, or complications.
Yeah.
All right, so again, so it has to be reviewed by his doctor, and they can make a decision.
Absolutely, on a continuous basis.
Okay, there was a time, a slide where you were showing the erosive and non-erosive, the complications of reflux disease.
If we could go back to
slide 7.
And this is where we stopped a bit earlier. Now, often reflux is a very worrisome symptom. And the greatest worry is that reflux disease predisposes to a condition known as Barrett's esophagus. Barrett's esophagus is just a name. It was named after somebody by the name of Norman Barrett. But basically, it's when the mucosa or the lining of the food pipe undergoes a change and it becomes similar to that of the stomach, in simple terms. And as a result, just to be able to withstand all this acid, but that change can cause more problems. It can cause one to become malignant. And the next step after Barrett's esophagus, it serves as a predisposition to developing cancer of the esophageal pipe. So that is the importance with reflux disease, is if it's not treated and if it's going on persistently, by doing endoscopy, you will hopefully be able to pick up the Barrett segment or the Barrett's esophagus, and thereafter you will be able to determine or the risk of developing cancer of the esophagus.
So then your message is, how long should reflux be treated then?
Well, the guidelines suggest that reflux disease should be treated, reflux esophagitis should be treated for the period of 4 to 8 weeks, 8 weeks generally. And after that, the patient is assessed again in terms of symptomatology, and then we cut down the medication. So then they're taking the medication either once a day then, or twice a day, or once every 2 days, according to their need, so according to what they did.
But is it daily forever?
No. We try not to give it for them forever. However, there will always be a group of patients, like we heard with the other caller, that once he stopped his therapy, he started having symptomatology again. So there will be that group of patients that will require this medication for a long period of time.
And based on symptoms?
Based on symptoms, yes.
Okay. So in terms of the reflux disease, before we move on to peptic ulcer disease, the lines are open, 011 086 7700, or 1 or 2 or 3. Please do call in. And you want to wrap up something on reflux in terms of lifestyle, or you want to move on to discussing a few important points on peptic ulcer disease?
I think let's talk on lifestyle for a few minutes, because that's a very important thing. So if you are suffering from reflux disease, these are simple things that you could perhaps do at home. Obviously, we said weight loss is paramount and it's important. Elevating the head of the bed. And this doesn't mean sleeping on 3 or 4 pillows extra. It literally means elevating the head, which means putting a brick, etc., at the bottom or at the top part of the head and elevating it. And that purely works on the gravitational mechanism. Stopping smoking, and this I think is very, very important. Majority of the patients that we see have got a significant smoking history, and this affects this valve mechanism. Obviously, alcohol intake must be limited. Avoid aggravating foods that we've discussed later or earlier. And those would be some of the lifestyle modifications that one can do to try and prevent, not really prevent, but try to control the reflux disease.
Okay, and that's in addition to obviously the medication that you may need.
Absolutely.
And a combination of the two.
Yeah.
All right. So basically we've discussed reflux disease. Nazir, we don't have much time left, but perhaps we can just touch on peptic ulcer disease, which is a related condition, again with acid and lifestyle and food.
So we're going to go through peptic ulcer. I'll just tell you quickly what peptic ulcer is. Peptic refers to acid, and an ulcer is a break or a little bit damage to the mucosa. And there's different types of peptic ulcer that you get. One is a duodenal ulcer, an ulcer that occurs in the small intestine. The gastric ulcer that occurs in the stomach, and ulcers that can occur elsewhere in the gastrointestinal tract as well. So in a nutshell, how do they present? So let's go to slide number 14 and 15, and this will tell you how a patient with peptic ulcer disease presents. Particularly,
symptoms are different, right?
Symptoms are a bit different, yeah.
Okay.
So abdominal pain, and particularly in the middle of the abdomen. What's interesting is that patients that complain about pain that occurs 3 hours after eating a meal may imply that they've got a duodenal ulcer rather than a gastric ulcer. Bloating, abdominal fullness, nausea, vomiting, loss of appetite and weight loss, and also bleeding. This is very, very, very serious. If anybody is vomiting up blood, if anybody is passing blood in the stool, or if the blood is if the stool is black in color without having taken other medication like iron, then these are warning signs that a patient may have a bleeding ulcer. And this is catastrophic. This needs to be treated immediately.
That's an emergency, a medical emergency.
Absolutely. Yeah.
So some of the complications are bleeding, and obviously when the ulcer bursts, what we call a perforation.
Sure.
You want to mention some of those danger signs or alarm symptoms?
Okay.
When it's a real problem, and it's a take-home message for today, I believe.
Okay. So, to all the listeners, you know, ulcer disease is a very big talk.
Bring up slide 10,
so
please.
I'm going to look at slide number 19. Okay. So, if anybody has got the following symptoms, they're bleeding, whether it be from the vomiting of blood, or they notice blood in their stool, or they notice blood when they go to the toilet. If they've got weight loss that is unintentional, difficulty swallowing, persistent vomiting, or if the doctor told them that they've got anemia, or if they've got a fullness in their stomach, then these are the warning signs. These are patients that need to be referred urgently to a gastroenterologist. These are patients that need to have urgent endoscopy done, because these are signs that are going to basically prognosticate what the patient may have, and also diagnose, and hopefully be able to offer them treatment very quickly and urgently. Okay.
In terms of the difference between acid reflux disease that we spoke about and peptic ulcer disease, we mentioned some differentiating symptoms. In terms of the diagnostic technique?
Again, for peptic ulcer disease, the best diagnostic technique would be in gastroscopy, so endoscopy. Barium does help, but not as effective. And again, the advantage of endoscopy is that you're able to see the ulcer. You can take a biopsy of the ulcer. And very important, because a gastric ulcer has got a very big risk of becoming a gastric cancer. So that's the important thing. Just go to one slide, slide number 16. What are the causes of peptic ulcer disease?
That's right.
And I think this is important. Slide 16 for us. Now, there's 5 or 6 different things that we've put up on the slide there. One of it is Helicobacter pylori, and maybe some of you have heard of this here, but it's a little bug that lives in your stomach, and it causes a bit of havoc now and then. That can be one of the contributing factors to developing duodenal ulcers particularly. But something I want to touch on particularly is number 2, non-steroidal anti-inflammatory drugs. What are those? Those are medications that we commonly use for pain, for joint pain, for arthritis. Amongst them, Grandpa, Brufen, Disprin, Compral, Anodin, the diclofenac, Voltaren, Celebrex, Acoxia, all these medications that we are dispensing or that patients are using for joint pain, if they use it chronically, can predispose to them developing a peptic ulcer. And that's very important again.
And it's important for them that, look, they do need this medication, especially people with severe arthritis.
Sure.
So perhaps then they should just look at alternatives, maybe cut down doses, take a bit of a holiday from that treatment.
Absolutely.
And use another treatment that doesn't have the same risk factor,
Yes.
and then perhaps go back onto it. And the other one that you mentioned, which is very common, there is the corticosteroids.
Absolutely.
Obviously, the steroids and the prednisone that a lot of our patients require. All right, so basically we discussed all the treatment. The treatment would be, in this instance, again, your PPI, which will be the final,
Again,
or the Rolls Royce of treatment in this particular case.
Again, it depends on what we find as the cause. The best treatment is to stop the offending agent. So if the patient is continuously taking something that would cause it, to stop it then.
Okay, very interesting discussion. We've run out of time. We have very good callers today with interesting calls, and we hope to have another show, Nazir, inshallah, to bring you back. Jazakallah for your viewership, and again, we'll be back next week with Health Matters. Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum.